Hello, my name is Curtis Olson. I'm an emergency department nurse in Lincoln, Nebraska. Our topic today is non-cardiac chest pain. The name of the presentation is, If It Isn't an MI, What Is It? We'll be talking about the evaluation and diagnosis of non-cardiac chest pain in the emergency department. Now, I have also worked as an EMT, as a paramedic. For those of you who are in EMS, I offer plenty of material for those of you in those roles because I've worked there and have relevant things for our clinical practitioners and as well as our field practitioners. I work in the emergency department at St. Elizabeth Regional Medical Center in Lincoln, Nebraska. We're a 250-bed community hospital. We have a regional burn center. That is where I worked for my first year of nursing school before moving to the emergency department. We have a NICU, we have a chest pain center, we have a cardiac cath lab, we're a recognized stroke center, and then we are an ANCC recognized magnet hospital. Our emergency department has 25 beds. We see about 30 to 35,000 patients each year, so a fairly busy place. Got plenty of experience, so I can teach you a lot of different things for case studies here. And just talking briefly about me, my original bachelor's degree is in English literature. That served me fairly well, but it just didn't give me a lot of really satisfying career choices. In 1994, I took my first CPR and first aid course, and I was hooked. I started volunteering with the Bethesda Chevy Chase Rescue Squad in the suburbs of Washington, D.C. Really good place to get very good experience and very good training. When I moved out to Nebraska, I went to Creighton University through their paramedic program, graduated there in 1998. Worked on Lincoln Fire Department for a year. Didn't find that satisfying, especially the 24-hour shift. So I went to nursing school, got a nursing diploma in 2003, returned there to Bryan School of Nursing in 2010 and completed my bachelor's degree there. And I am a certified emergency nurse. That's a credential through the Emergency Nursing Association. So our topic today is chest pain. And when you talk about chest pain, typically people think about cardiac chest pain. And I will talk briefly about that and a few clinical pearls to consider when dealing with you in the initial moments of your chest pain patient. But the bulk of my discussion here will be about non-cardiac chest pain. So after you've gotten that 12-lead EKG and it's showing they're not having an acute MI, then what do you do with them? So in our emergency department, our very first minute assessment and treatment of these folks starts in the very first minute. From the minute that person walks up to our registration desk and says, I am having chest pain. The registrar and the triage nurse will get that patient back to a room just as quickly as we can. We send out a page to all the staff, the nurses and our technicians, to get a nurse in there and to get an EKG. And the triage nurse will stay with that patient until a primary care nurse can take over with that patient. Now, if you're old enough, or that is to say, if you're lucky enough to be experienced enough to remember this young lady, this is Gilda Radner on Saturday Night Live back in the late 70s. She had a character called Rosanna Dana, and if you remember her little shtick, it involved, she would talk about, you know, I have a lot of problems, my head hurts, my feet hurts, my back hurts, I'm peeing blue, blah, 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 and you have a lot of patients who present like this. I've been having trouble breathing, I have this cough, my left leg hurts, and if part of all that is I have chest pain, we're going to have to go through this protocol to get them right back to a room and get an EKG right away. So we're going to start that hunt for MI and hook them up to all these wires here to get the 12-lead EKG. And so our protocols and the guidelines from the American Heart Association emphasize to do that within 10 minutes of presentation. Now, I have another 45-minute discussion of just this 10 minutes that I will spare you here, especially since we're talking about non-cardiac chest pain, but there's a lot that goes into this, and I'll give you the Reader's Digest version of this. In any case, that machine will spit out this 12-lead EKG, and those machines have a semester of cardiology packed into them, and what they're looking for is this ST elevation. Here's a normal ST elevation. It should be on the isoelectric line of the EKG, but if we have elevations in a few leads on the EKG, that's indicating that they are having an acute cardiac event and they need to go to the cath lab. And if you're like me, that's 50 yards down the hall. I know I've talked to a lot of rural nurses and EMS providers who are far away from a chest pain center like us, so their cath lab is more like 50 miles down the road. But we need to get them there, however we're going to get them there, whether it's on a stretcher, or an ambulance, or in a helicopter. The reason we need to do this right away is when you have an acute blockage in a coronary artery, the longer that blockage is there, and the longer you have a certain segment of the heart muscle that's deprived of oxygen and blood and all that kind of stuff, that muscle will start to get damaged and then will start to die, and that will not be restored when we restore circulation. So our emphasis at St. Elizabeth Hospital is a 5-minute door-to-EKG time. It is an internal quality measure for us. It's tied to the hospital ratings that the federal government is now putting on their websites, and our annual pay increases are tied to this quality indicator. So consequently, we page out that EKG, and everyone is just piling into that room and helping out and getting that initial assessment going. Now, when you think about MIs, when you think about chest pain, this is the guy you see. This is out of my very first CPR textbook that I used in 1993. And chest pain, heart attacks, you think an older guy, maybe a smoker, maybe a drinker, a lot of steaks and red meat, maybe not a big exerciser, with pain in that red zone, or right in that substernal area, maybe radiating out to the shoulders or up to the neck. But there are a lot of people, in fact now the vast majority of your chest pain, of your MI patients are not presenting in this. Classically, we talked about that substernal chest pain, crushing or heavy. Usually we talked about, in discussions of this, they talked about the Levine sign. That's a closed fist right on that sternal region. That indicates not only the location of the pain, but that kind of crushing, constricting quality of it. But so many of these MI patients aren't presenting like this. In fact, probably just a little over than half of them, according to the American Heart Association. And not all MIs are going to present with that chest pain. So here are a few examples from my triage desk. A guy comes in, he's sweaty, and this is February, and he is sweaty, literally dripping onto my triage desk and saying, I just don't feel good. And a little more discussion, well, he's a diabetic. We'll talk about how diabetics kind of present a little bit differently. But he was having an acute MI, and we got him to the cath lab and got him open. And one of my doctors, in retrospect, classic clinical pearl. Sweaty is bad. I hate sweaty. So sweaty is bad. If you forget everything else I tell you, you can kind of remember that. Guy comes up to the triage desk, says, both of my arms feel like lead. And first thing goes through your mind is CVA, stroke. But negative for stroke symptoms, nice symmetrical face, clear speech, can move the arms around, but they just felt strange to him. I don't know what's going on with you, buddy, but let's get an EKG. Let's start with that. He was having an acute MI and went to the cath lab. I was laying in bed, turned over, and started having this left shoulder pain. And you think, just musculoskeletal, but it didn't change, no change in any movement. That pain stayed constant. So got an EKG fairly early on, and he was having the big one. And one other one, we had a nurse who works in our local cardiac hospital, moonlights with us in the ER. So I was orienting her to triage one night, and in comes this guy, says, I've had this cough all week, and now I have this burning in my chest. And I'm thinking, well, he's coughing, he has some, musculoskeletal strain in his chest. And Lisa says, well, we should get an EKG on this guy. And I'm thinking, well, she's a cardiovascular nurse. I think I'll listen to her. And thank God I was orienting the newbie to triage, because we got the EKG, and he went to the cath lab because he was having an acute MI. So a lot of very unusual presentations can be MIs. American Heart Association talks about these groups of patients that present in unusual ways. Let's talk about these weird outlier populations. Well, first of all, there are the elderly. Well, who has MIs? The elderly do. So 12% of our population is over 65. And as these patients get older, they accumulate a lot of comorbidities like diabetes, which we'll talk about, and high blood pressure, things like that. So their symptoms are going to be a little more vague than that classic chest pain. Diabetics, because of their constant high blood sugar and neuropathy, they're not going to have the usual pain responses of most folks, and they're going to present without that chest pain. And they're going to be sweaty. They're going to feel just a little weird, maybe a little short of breath. And there are about 16 million diabetics out there. And then what's our weirdest, wackiest, most outlying population? It's women. 50% of the population, obviously. And in the last 10 years, with more studies, they've realized women present with these very atypical symptoms, without chest pain, just feeling tired, a little bit off. I think it's because women have higher pain tolerances, and then also women tend to have their cardiac events later in life, so they're getting older and accumulating more of the comorbidities, maybe are diabetics and other things. So they will present without these usual classic symptoms. So consequently, everyone gets an EKG, or everyone with any kind of discomfort between their nose and their navel is a good candidate for an EKG. So that's my very brief cardiac chest pain lecture, but the flip side of this is that not all chest pain is cardiac, and that's the bulk of what I'll be talking about today. So you get that 12 lead, and it's negative, and I was like, whew, wow, that's great, but your work is just getting started, because there's a whole lot of things that can cause chest pain that aren't cardiac, but that can be just as deadly and just as immediately deadly as your MI. So that's what we're going to be talking about today. Now, the chest is not a simple collection of structure. The chest has a lot of things going on. Anything that involves circulation out to the body, anything that involves gas exchange, oxygen exchange is in there. There are a whole bunch of tubes and muscles and stuff going on. So there is a lot to look at when your patient is having chest pain. So let's look briefly at our objectives. We want to review your priorities of care for chest pain in your pre-hospital or in the emergency department. We just did that. You know, we want to get them an EKG, and if the EKG is negative, move on with our diagnosis. So we want to look at the implications of specific physical exam things you can pick up right away that can lead you toward a diagnosis. We'll also talk about lab and x-rays in the emergency setting, and then review the pathophysiology and treatment of these conditions that can cause chest pain. So what we're going to do is do a case study format. I'll talk about the presenting signs and symptoms of these patients, your physical assessment on them initially, what we'll do in the ER with labs and x-rays to take a look, and we'll finally get to that cardinal finding, that differential that will lead us to a final diagnosis. Now sometimes it's going to be easy, so there are some nursing textbooks and a very few EMS textbooks that do a complaint-based format. We'll say, chest pain patients, this is what you're going to do. Most do a system-based, cardiac problems, GI problems, neuro problems. Whatever kind of textbook or format you're using, there are some things that are pretty easy right at the front of the textbook. This is the thing that can kill you right away, that's very common. We'll look at it. As we dig deeper into this presentation, we get into the more unusual ones, the ones toward the end of the chapter, the ones you probably fell asleep before you got to, the rare ones, the exotic ones. So we'll get into this fairly deeply and talk about some common deadly and some less common and less deadly ones as we move along here. So we'll start with the easiest and obvious one and move on to the stranger ones. So our very first one, probably a pretty easy one, patient is short of breath. They come in, they have sharp chest pain. So instead of that Levine sign, it's very specific. They can use one finger, they can point right to where it's hurting. Chest pain is sudden, it's sharp, and very localized. Going to be breathing a little faster, heart rate's going to be up, they're going to be anxious. O2 saturation is going to be low typically, and their lung sounds are going to be clear, completely normal bilaterally. So, because I can't interact with you directly, but what do you think given that presentation so far? Now what's our treatment or initial management for all of our chest pain patients? Going to get some oxygen on them, typically, although there's, that's undergoing some review right now, and I won't get into that. Yet another lecture I do here. But EKG, monitor, get those vital signs, get an IV going. Our typical lab work, hematology, chemistry, chest pain panel, looking for those chemicals, those enzymes that the heart sends out when it's having problems. Maybe check some bleeding times, PT, INR. Get a complete history on them. Now my EMS folks know about the sample history and the OPQRST. This is pretty normal nursing charting too. but just kind of a little mnemonics to help you out there, and I won't get into detail on that. If you're in EMS, you know those mnemonics, and if you're in the hospital setting, most of these are probably part of your assessment anyway, but you can look up these mnemonics that might help you. And then always, always, always lung sounds. I'll talk about those in some detail a little bit later. Now going back to this sharp localized chest pain, 90% of these patients have excuse me, one of these following risk factors. They've been immobile for a while, typically bed rest, although when I present this at large conferences, I say long train or plane rides can also contribute to that. Some of them have heart disease, a lot of them will have cancer, estrogen therapy, by that I mean using oral birth control, and maybe a history of DVT at some point. Chest x-ray is going to be normal in the ER. Digging deeper, we can do a couple of things. We can do a CT scan of their chest to look at blood flow in the chest. A lot of times before going down that road, we'll do a test called a D-dimer. That is kind of a blood clotting test, and that's kind of a screening test for this diagnosis. So if you haven't thought of it already, our diagnosis here is a pulmonary embolism, a blood clot in the lungs. Now, when you have a blood clot in the lungs, typically there's been some blood clot in the body, typically in the legs. It's been dislodged, it's made its way through the right atrium and right ventricle, and then into the pulmonary circulation. And in there it goes to the larger, and then smaller, 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 and finally finds a place where it just can't get through, and we have a blockage there. So this patient can breathe, the air can go in and out, but they can't do that oxygen exchange there because we have some segment of the lung that doesn't have blood flow to it because of this pulmonary embolism. Sometimes this could be a very small one and insignificant, maybe an incidental finding with some other things. Sometimes it can be very significant, sometimes almost immediately deadly. They might not even get to your emergency department. Excuse me. So can be immediately deadly or fairly minor. They can also have a real scattering of a lot of subtle ones that will add up to some pretty bad damage in the aggregate. But that's our pulmonary embolism. Other risk factors for these smokers are a little more prone to them. Pregnant women can have amniotic fluid clots get thrown out there. Recent surgery, also long bone fractures can throw off fat emboli from those fracture sites. And then long airplane rides like I talked about there. So let's look at our next case here. Very similar presentation, typically an sudden onset chest pain and sudden onset shortness of breath, breathing a little faster, heart rate is up, O2 sat down, and they're kind of anxious with this. Lung sounds, however, are diminished on one side, so always be listening to your lung sounds. Their late sign, or often too late or fatal sign, is tracheal deviation. Again, kind of an easier one to remember. Look at a chest x-ray, and this is what you're going to see on the patient's left chest here. You see this kind of spidery stuff there, which indicates good blood flow and healthy lung tissue there. On this side, lots of air, which is good in the lungs, but that's all we have in this pleural space. And you can see almost like a deflated balloon here, which is that lung tissue that's gone down. So I've already told you our diagnosis on this. This is a pneumothorax. And this can be an open pneumothorax, a traumatic pneumothorax, or a spontaneous one. Someone was just sitting there. I was just smoking my cigarettes and whatever. And I'll talk about a few different mechanisms for that. Here's a clearer version of this, and this one is an open, traumatic one. This patient has had some sort of penetrating trauma here. So every time they breathe in and every time their chest cavity was expanding, maybe a little bit of air was coming in through the normal airways, but air is also getting sucked in through this hole in the chest. And every time they do that, that increases the pressure on this patient's right side, and this lung is starting to deflate. Now you can also have a closed or spontaneous pneumothorax, or one that comes from blunt trauma, where you don't have this hole here, but some weakened area of the lung tissue has popped open a bleb here. So again, every time they breathe in, air comes into the trachea and the airway, and then is flowing out of that lung into the pleural space here. So as they breathe and as that continues, air starts to invade this pleural space and push this lung tissue and collapse it. I had a patient who was in the ER. He had been in a bike accident. He had a dog had run in front of him. He hit the brakes, flipped over the handlebars. As he was hovering in that air for the half second, he was probably watching the ground come up to him and say, "Oh, this is going to be really bad when I hit." And tensed up, closed his glottis. So when he did hit, he had a pretty good jar to the lung, and that literally did pop it. It didn't pop it like a balloon, but it popped open a little bleb. So he comes in complaining primarily of shoulder pain and had some abrasions there. But on listening to his lung sounds, we have some decreased lung sounds on that side. Got the chest x-ray and saw that classic pneumothorax. Now we did have a trauma surgeon come in and start a chest tube on him, which is probably a lot more than we needed to do because his pneumothorax was not that large there. But that's a example of a traumatic closed pneumothorax, non-penetrating pneumothorax. So it can be traumatic either with blunt trauma or with penetrating trauma, which you kind of think more commonly. Iatrogenic, that's a fancy name for caused in the hospital. So after a doctor puts in a central line or a pacemaker or does something in the subclavian area, we will always get a chest x-ray to make sure in the process of jamming things blindly in this patient's chest cavity that didn't pop the lung in the course of that. Also spontaneous. Patient is just does something, was exercising, smoking. I'll talk about one other in another section, another kind of unusual mechanism for this. But then all of a sudden they just started having some chest pain. Our emergent treatment for this is needle decompression, and then further down the line, a chest tube for more definitive management if needed. So I have a colleague who worked in the CCU in the hospital in Grand Island for some years. He had a patient one night, intubated, sedated patient, who all of a sudden started coding. So of course they all went in there, start doing chest compressions. Now think of the first time you did CPR, and you did it on like a 60-year-old, and you think, this is great, nice and springy, just like the mannequins in my CPR class. And then the first time you do it on a 90-year-old, you think, oh, this is just like a bag of Doritos, this is horrible. And he starts doing chest compressions on this guy, and it's like an overinflated tire. He just could not get a compression. He realizes this person has blown a bleb, they're having a pneumothorax. And there was no, let's call the doctor, let's get a chest x-ray and such. This patient was coding, so he just grabbed a 14-gauge catheter, and this is where we want to go, in the mid-clavicular line, with a large bore needle, over the top of the second intercostal space. You want to go over the top. On the lower margin of each rib, you have some nerves and blood vessels you don't want to start ripping around on, so you go right over the top, and you should hear this nice satisfying little hiss as you're really re-inflating that lung and evacuating that air out of the pleural space. So other risk factors for this: gunshot wound to the chest, obviously that's a good mechanism for the pneumothorax. Smokers will be more prone to this. Tall and thin people tend to be a little more prone to spontaneous pneumothoraxes, or thoraces, whatever. Marfan Syndrome is an extreme example of these tall and thin folks. And if you're not familiar with that, these are people who have a very characteristic look. Their shoes typically have to be, custom made because they're size like 18. Big hands, kind of unusual facial structures, kind of larger foreheads and such. They think, well, there's a lot of historical pathology done on Abraham Lincoln, so they think that's something he may have had. The great blues guitarist Robert Johnson, they think he did it. He had Marfan Syndrome, because look at these long, long spidery fingers. And when Eric Clapton tried to duplicate some of his performances, he couldn't do it because his fingers just weren't that long. And then everyone thinks Michael Phelps has Marfan's. He denies it. He just is has a freakish anatomy, but he says it isn't Marfan's. He's just a really good swimmer. So Marfan Syndrome is also a risk factor for our next thing I'm going to talk about here. This patient comes in with chest pain, also back pain. Now they, instead of this very calm Levine sign, are going to be very, very uncomfortable. That pain they talk about is ripping and tearing, like something's just pulling them apart. Upper back pain typically also. Also, they're typically going to have some blood pressure problems, and that really depends on the underlying pathophysiology, but it's not unusual for them to have syncopal episodes involved with this. Diminished pulses, and sometimes you will have a difference in the blood pressure, a difference in the quality of the pulses between the right and left arms. Check those pedal pulses on these patients. If you can, you're going to be chasing them around because they're going to be so uncomfortable. But their legs might be pale or even cyanotic. They're going to be very restless. And the 4 patients I've seen with this, they always talk about in the textbooks with MIs and some of these other things that they have that impending sense of doom. And in the classroom setting, that kind of evokes a chuckle in the class typically. These patients, the 4 I've seen, they came in and they said, I feel like I'm going to die. And I believed them because they did look like they were going to die. 3 of them did die right in front of us. Our ER findings, chest x-ray is going to be abnormal. Contrast CT of the chest is going to be our definitive diagnosis if we can get them down there in time. But we check those pulses, radial pulses and pedal pulses on these patients, reporting this really uncomfortable chest pain with this anxiety. And what this is an aortic dissection. Now, people tend to use the terms dissection and aneurysms kind of interchangeably because they're both the aorta. There's a problem with the aorta. But they are very, very different. I'm going to talk about both of them here. Dissections being very often quickly fatal, and aneurysms something they might carry around for years or even decades without any need for management. So let's look at the layers of an artery, and this is true of the aorta and every other artery you have. If you've ever had the privilege of being in a cadaver lab, you've seen the aorta is literally the size of a garden hose. It is a very large blood vessel coming out of that left ventricle and sending blood out to the whole body. And like every artery, has 3 layers. It has outer and inner epithelial layers, or endothelial and epithelial layers, and in the middle a muscular layer. And that is what controls dilation and constriction of that artery, so we can control our peripheral blood pressures and blood flow and all that kind of stuff. So what these dissections are is some sort of breach happens in the inner layer, and blood starts to flow into the intima of the artery. It goes in between that epithelial layer, or endothelial layer, excuse me, and the muscular layer, and starts to fill that up. And as it starts to fill up, it will start to interrupt blood flow as that ripping continues down into, in this example here, down to the femoral artery. If it extends down this far, it's going to interrupt blood flow down here to this left femoral artery, so you will have diminished pedal pulses in this leg. This is class 1, class 2, class 3. I'm not going to get into detail. These are different flavors of really, really bad. So if it starts up here as it extends into the patient's right brachial artery or right carotid, we're going to lose blood flow to half the brain. Now we'll have the circulus villus and still have some blood flow there, but then we're going to have diminished pulses out to that right arm. These can also go along where it extends into the coronary artery. So in addition to all the other nastiness that's going on, we're losing blood flow to the heart also. So as it continues and interrupts blood flow, this is insanely painful. We're also having a certain amount of hypovolemia as this blood is leaving the circulatory system. Now by contrast, aneurysms, much better. These can be acute and can happen quickly, but these are more typically, these patients will start to, this is where all 3 layers of the artery have a weakening, and they start to pooch out, and this can happen in the abdomen or even up in the thorax. Often it's an incidental finding with something else. Often they know this is going on, so if you ask your patient, what kind of medical history do you have? They said, oh, you know, I have an abdominal aneurysm, and they typically track that once a year with a CT, and we'll say, oh, we can let this go for another year, and at some point it's going to need some controlled surgical management. In some patients, this will be an acute problem. They develop it very suddenly, and it may need more emergent surgery. When I was in a working with some students from Union College in Lincoln. We went to a rural clinic in the middle of the jungle in Nicaragua. And literally my first day, my third patient, she said, I've got this belly pain, and I feel in there, and our cardinal sign of this abdominal aneurysm is that pulsatile mass, which I had never felt until I had to go all the way to Nicaragua to feel it. And I was like, oh, wow. And I called in a few students to feel. I said, do palpate gently, but do feel it. And she had said this has been going on for years and years, so she was also 60 or 70 years old, which was ancient by the standards down there. And I'm thinking, well, maybe Mexico City, maybe Buenos Aires, but we're not going to fly this woman out of Nicaragua for, probably $1 million operation. So she, this was nearly 10 years ago, so she was probably dead of this or some other causes by then. But with our abdominal one, it can be a pulsatile mass. And again, typically this isn't an emergent problem, but can be in there. Next one. Next case, patient comes in, feeling short of breath, maybe, definitely chest pain. Well, what were you doing? Oh, we were just hanging out. So of course you have to talk to him a little more. Further questioning, cocaine or methamphetamine can cause this. Vitamin K, which isn't typically one of your prescription patients out there, but also Imitrex, the migraine medication. So all these can, and then often happens at night, just because that's when a lot of people are doing their cocaine and meth, but not always. And I'm sure you've gotten your share of drunks who are drinking at 2 o'clock on a Thursday, and you wonder, where did my life go wrong that I'm here working and you're out having a good time then? Now, they're on an EKG. For a lot of these patients, you will have elevations on the EKG. It will look like an MI on the EKG, but it's not always. These medications can cause a coronary vasospasm. So there is not a blockage in that artery, but those arteries, coronary arteries, will constrict and cause an interruption in the blood supply to the heart. Often it'll resolve on its own if they don't die. And I've never seen any of these people die, but they'll have these coronary vasospasms, which will show as ST elevations on your EKG, and then it will resolve. Maybe they will get to the cath lab, or maybe it'll just resolve spontaneously before we get there. Another name for this is Prinzmetal's angina. So, and then I also had, speaking of meth and coke and drugs, I had another patient come in, had been smoking methamphetamine and complaining of chest pain after this. So I was thinking maybe this coronary vasospasm. His EKG was normal, but on his chest x-ray he had a pneumothorax. So what's our mechanism of this? Well, he smokes and then holds it and bears down, does this extreme Valsalva, and after years of this, popped a bleb and caused a pneumothorax. He decided to leave AMA rather than stay around for observation. And during the course of this, he says, well, do you think I overdid it on the meth? And I had to reply, honestly, I think any methamphetamine is overdoing it, sir. And consider that, well, that's an honest answer. That's all I can offer to you. So here's a little slang quiz for you here. Is it meth or is it coke? So rock, that is cocaine. Tina, that's a regionalism for one brand or another of methamphetamine. Blow is cocaine. Strawberry Quick, another kind of regional methamphetamine. This basically goes meth, coke, meth, coke, meth, coke. If you want to learn drug slang, WhiteHouseDrugPolicy.gov is the best. ATF reports any of their slang to this site, and they put it up there. So a lot of really crazy slang names for meth, coke, heroin, what have you. And this isn't the new, cool Barack Obama White House. This was a cool website when both of the Bushes were in there. So here are a whole bunch of other cocaine ones. Being from Washington, D.C., our former mayor, Marion Barry, was a big fan of Beaming Up to Scotty, which is freebasing rock cocaine. And then here's a bunch of meths, including, well, I don't have it up there, but on that other screen I had Strawberry Quick. A lot of their meth cookers want to create kind of a brand loyalty, so they'll put in something so it gives you a special color or a special appearance. So that guy who put together Strawberry Quick, his adulterant may well have been Strawberry Quick, but he did something to make it pinker. Now, working in the burn unit 10 years ago, I was seeing a lot of meth cookers, but it seems like a lot of that has been outsourced, so we're not seeing those sort of regional ones, at least not domestically cooked up stuff there, but it's obviously still out there, but I think a lot of it nowadays is coming from Mexico. Kind of related to the coronary vasospasm, whether it's caused by drugs or by something else, is this, I used to try to pronounce this, I've given up, but this cardiomyopathy. This is a cardiomyopathy that typically is stress-induced, and the most typical stressor for this is an older patient whose spouse has just died, and they are very depressed and having a lot of stressors in their life, and this will cause this this spontaneous cardiomyopathy and heart failure, and oftentimes this will also lead to an MI. And this is not named for the Japanese cardiologist that came up with it, which is what you'd think, but I think it was named in Japan because what it is named after is, if you enjoy sushi and enjoy octopus, this is how octopuses are captured. And these octopus, and this is what a Takotsubo is. This is an octopus trap that they use in Japan, and they name it after that because on an echocardiogram, on an ultrasound of the heart, it does have this very distinctive appearance that looks like this octopus trap. So there's some extreme trivia for you. I did mention also that Infiltrates can cause those coronary vasospasms, and that is kind of another kind of odd pathway that your patient might take in the ER. Someone saying, I had well, at least with one of my providers, Dr. Ann, I'll call her, a patient comes in saying they had taken some Infiltrates, their migraine wasn't any better, but now they're having this chest pain. So we did a whole cardiac workup, and the doctor very sweetly said, well, you're not having any kind of coronary problems, and so we can let you go. And they're still like, all they wanted was their migraine taken care of, and we kind of sent them out without that sort of management. So if you're out there listening, I apologize for that. So our next one here, chest pain can be typically is a gradual in onset, but this can come on very quickly. And these patients can come in looking like your MI or like your AAA patient, where they're coming in with very sudden, very intense chest pain, typically associated with a cough, and they're definitely going to be feeling short of breath also. They might have a wheeze, and then the real differential for this right up front, you're going to get this right up front, is a fever. So someone will come in, and I actually have gotten into, you know, glancing first 10 seconds diagnostic matches with some of my colleagues, where we have this MI patient or this chest pain patient, we're getting the EKG, and I'm saying, get the temperature, this is pneumonia. No, I think it's a AAA, and we kind of go back and forth until somebody gets a temperature on it. Answer here is pneumonia. And for my EMS providers, I really want to emphasize that temperature can be a very, very key vital sign for in the field for your chest pain patients. Because more than once, seen EMS providers come in, and the presentation of the patient is this chest pain, the wheeze, the shortness of breath, and they're not checking the temperature, and absent that, they're going down this kind of pulmonary edema protocol, giving nitro and Lasix to a patient who really needs fluids to treat that pneumonia that they have going on. So if you do have a thermometer on your rig, do know your way around it, and do give it a whirl every once in a while. So here's our definitive diagnosis on these is just a plain chest x-ray. So here's kind of an extreme one. Again, normal lung tissue over here on the left, on the right, patient's right. You can see these infiltrates where they have an infection. They've got some internal edema there because the body is trying to get a lot of white blood cells there to work on this infection there. With these patients, we want to start an antibiotic within the first 4 hours of their hospital arrival. This is associated with decreased complications. It's also a requirement from the feds for our Medicare patients. So including one of those decreased complications is better reimbursement for us in the hospital for treating these pneumonia patients. So again, rapid assessment is important for these folks, even though they aren't going to be keeling over right away. A lot of other things can cause those kind of white patches on the chest X-ray. Pleurisy, that would typically be more of a chest wall infiltrate there, but still look unusual on a plain film chest. Empyema would be the same kind of thing, but with more of a collection of pus and nastiness in there. Cancer and tuberculosis also are associated with these infiltrates on the X-ray and chest discomfort. If you really want to go old school, you can go around and percuss them. Well, fortunately, we do have chest X-rays, but I'm sure you went through this in nursing school. Maybe in EMS school, although typically not. Now here is my favorite chest X-ray. Emergency Physicians Monthly has a blog, and this was off of their blog. I love this. This is what one of my ER providers would call a plumber X-ray. As you're looking at this, the plumber wanders by and he'll look at it and say, "Oh, that ain't right. I don't know what's going on." And this is definitely a not right kind of thing. So we have obviously a huge fluid collection in this patient, and you kind of throw up your hand and say, "Well, I don't know what that is." So to diagnose this further, let's send them down to for a CT. So for the chest X-ray, they're standing or sitting up. In CT, of course, they're laying down. Well, there's that same fluid, but now it's sloshing down to the patient's posterior there. So we got a whole collection of something in there. So we got to get it out. So we'll do a chest tube. So if you've ever seen a chest tube done, or you do an incision in the patient's axilla, very careful advancing of a finger or maybe a hemostat to go in there, and you don't want to puncture the lung, but you want to get into the pleural space. Typically, you want to do this very carefully, and oh my goodness, suddenly all this gunk comes coming out. I can't imagine what this must have smelled like. This is just this huge collection of pus. And this gentleman was not like on the verge of death. He had been saying, increasing chest pain and shortness of breath for some weeks. A healthy guy. They never did find the etiology of this just insane infection that he had. And this was in the pleural space, so we drained that lung, and it wasn't a pneumonia. It was just some sort of infection of the chest wall or the pleural wall there. And he walked out, after a lot of intense IV antibiotics. Here's one, maybe you've had this. I know I get this on a regular basis. Burning chest pain, typically worse after a meal, typically worse on patients who are supine. And I won't belabor the diagnosis too much here. This is GERD, gastroesophageal reflux. So after stressor, a meal, whatever, this sphincter here in the stomach, which by the way is called the cardiac sphincter, not because it has anything to do with the heart, but because it is parked right next to the heart there. Some problems with that, and that stomach acid will slosh up into the esophagus. And for the first-time patient, or for a really extreme episode of this, these patients will come in with this very intense chest pain, thinking they're about to die, which you will too, until you kind of exclude all the other causes for this. And for this, our treatment is a GI cocktail. Typically, this involves some Maalox, which is an antacid, lidocaine also, an anesthetic, so we can numb up the esophagus and treat that pain. A lot also, and this is old school or more of a regional thing. I know when I've lectured in the South, Atlanta, the Carolinas, they're still using Donatol, which is an antispasmodic, so that'll slow down some of that spasmy smooth muscle spasm that they might be having. That gives it this very lovely green shade, so it looks like one of the Green Goddess cocktails. Now, one precaution I would throw in here, and when I was always giving, for many years, as I gave a GI cocktail or as I gave nitroglycerin, I was thinking of these as treatment for the pain, but I was also thinking of them as sort of diagnostic tests. So if you gave a GI cocktail and that relieved the chest pain, then you had something of a pretty good diagnosis differential that they had GERD. Whereas if you give nitroglycerin and that resolved the chest pain, maybe that would push you more toward a diagnosis of cardiac involved chest pain. But really these are treatments, and actually each of these can treat the others. So for example, nitroglycerin is a smooth muscle dilator. So in addition to dilating the muscles in those coronary arteries and increasing blood flow there, it also relieves some of the spasming involved in GERD. So nitroglycerin can resolve to a certain extent some of that discomfort from GERD. Same thing with the GI cocktail. If somebody's having a cardiac event and having that chest pain, that stomach acid is going to be probably sloshing around there. So you're going to give them a GI cocktail, and that's not going to resolve the cardiac chest pain. But some of the it may be resolving some of the concurrent GI discomfort they're having. So these are very helpful for treating that pain, and we always want to reduce their pain, but they aren't diagnostic tests. So here's something a little more subtle. And I've seen this, and sometimes it can be life-endangering. Typically, it's a little more not so bad, let's say. EKG, and all these are subtle findings, and nothing's real definitive with these folks, and it's just kind of a diagnosis of exclusion. EKG oftentimes will show some subtle changes, but really nothing you can hang your hat on there. Chest x-ray typically is going to be normal. Labs, white count might be a little bit elevated. Chest pain panel, those cardiac enzymes that the heart sends out when it's having real distress, typically will be normal. But you want to listen to the heart sounds. Now, how many of you listen to heart sounds? When I have, 5 patients and ambulances on the way and a waiting room full, I don't listen to heart sounds. When I have 2 patients and I have a good reason to, or I'm just feeling very leisurely, I will. Lung sounds, we always want to listen to lung sounds. Heart sounds, maybe not so much. One of my first EMS preceptors made me listen to lung sounds on every single patient. I've got a cough, listen to the lung sounds. I broke my finger, listen to his lung sounds. Well, why am I doing that? Because you listen to lung sounds on every single patient, so you can hear them all on a good day. So when your patient is having a bad day, you really know the difference. Same thing with heart sounds. The more you can listen to them, the more you'll know what normal heart sounds are and where to listen on the chest and all that kind of stuff. And know your way around your own stethoscope and around your patient's chest. History and exam on these patients, again, very equivocal. It might be sudden or might be gradual onset. Typically the pain is worse when they're supine, and that's a pretty definitive one, but that's true of GERD too. They may have some shortness of breath, but on those heart sounds, they're going to have a pericardial friction rub. So when you listen to their lungs, you can hear the heart rubbing against that lining, the serous lining around around the heart. And that's going to feel like if you rub a couple of dry fingers by your ear here, that's kind of what it sounds like, or a couple of hairs, rub those together by your ear. A recent upper respiratory infection, I had a cold, and it's like fairly distant, like a week or 2 ago I had a cold. And then it's this viral illness that leads to our other thing, and our EKG changes. And an echocardiogram is going to be our definitive diagnosis. This is pericarditis. This is an infection of the pericardium, which is that sac that surrounds the heart and protects it as it beats and contracts and torques around in the chest. This can be life-endangering. There are some people who come in with this and they will be kept for a week or 2 in ICU with powerful antibiotics. It can also be treated outpatient. Really, again, very equivocal. There's a whole range of findings there. You can also have myocarditis, an infection of the heart muscle, and that will be very subtle with the history, but the chest pain panel, those enzymes will be trending up. And I had a patient who came in mid-20s, not a smoker, good exerciser, not a drug user, no risk factors, but we could watch as his chest pain panel, his troponins, was trending up over the course of the night. So even though he didn't have any cardiac risk factors, with that chest pain panel going through the roof, they had no choice but to cath him, and the cath was normal. So his diagnosis finally was a myocarditis, some sort of infection of the heart muscle, which obviously could have gone. He was very stable, but just having this very uncomfortable chest pain. So here are heart sounds, and you listen actually pretty far afield around the chest to really listen, get a good listen to all these valves and there's function there. Again, not something I'm doing on a regular basis or a systematic basis, but something you should do every once in a while to have a listen. So when you have something real out there, it can kind of clue you in. So now I'm going to talk about zebras. What do I mean about zebras? What I'm talking about is when you have medical students who have had decades of schooling, and then they are going out during their residency or internship for their first real patient encounters. So they have somebody with redness and swelling of the leg, and they'll look at them and do a history and physical and go to their attending. They say, he has redness and swelling in his leg. I think he has necrotizing fasciitis, or it could be leprosy. I think we're in the differential for that. And I saw this episode of Royal Pains where this guy had a parrot that was imported from South America, and he had a baby, I forget what it was called, and the attending will say, the guy's got cellulitis. When you hear hoofbeats, think of horses, think of the common things, don't think of zebras. So, I live in Lincoln. In Lincoln we have a zoo. The zoo does not have zebras. So if I were driving down O Street in Lincoln and saw a zebra, I would think somebody had snuck something into my coffee and that I was hallucinating. Omaha Zoo has zebras. So if I'm driving down Farnham Street in Omaha and I see a zebra, I will say, that's very unusual, but zebras are out there. They may have escaped from the zoo. So these are unusual presentations, unusual physiologies, but the zebras are out there, so if you know them, you might catch one of these days. So before talking about that, I also want to take a little compensatory pause here just to think about your typical shift. And every time, if you're an EMS provider, swipe it in, doing your gear check before your shift, or if you're a nurse, putting on your stethoscope and swiping in or punching in or whatever you do. We are in a very unique business because every time we come on shift, we could have the best day of our lives, best day of our careers, where we see somebody, we figure out what's going on with them, we cure them, and they feel better after we've taken care of them, and they say thank you. How often does that happen? Not very often in my department with those 30 to 35,000 patient visits, but it does happen. When it does happen, it is so fun. Might catch a baby, something like that, all those good things. We also are in a business where every time you put on that stethoscope, check your gear, swipe in, you could have the worst night of your life or worst night of a career where something goes terribly wrong, where you have a patient who is dying right in front of you, you know exactly what's going on, and you can't do a thing about it. That's our next case here. So let's take a look at it. Chest pain with decreased level of consciousness. As a patient, early 80s, she had been earlier in the week with a minor MI. She had gone to the cath lab. They had found 40–50% blockages. They put in some stents. She's discharged home 2 days later, doing just fine. Comes in, family reports, end of the week. She wasn't feeling good, goes into the bathroom, comes out of the bathroom, says she doesn't feel good, vomits, and has a syncopal episode. Is brought in by EMS. On arrival, she is very restless, very disoriented, very out of it. Now, I had seen her earlier in the week, so I talked to my ER doctor, and it was almost like this dementia look to her. And I said, this woman is not demented. She is 82 years old, but sharp as a tack, very with it. This is not her. This is not the patient I saw earlier in the week. These patients, and our initial assessment, we were thinking maybe something neuro. She was very, very restless, so we really couldn't get a decent set of vital signs, couldn't get a decent blood pressure. So with her restlessness, we're getting these artificially high elevated blood pressures. So we sent her down to CT for a head CT. On return, her level of consciousness has gone way down. At this point, we can get a decent set of vital signs, and we are seeing very low blood pressures, hypotension. These patients present with this classic triad, distended neck veins, hypotension, which we were seeing with this, and muffled heart sounds, if you are listening to the heart sounds on these patients. So does this ring a bell? This is Beck's triad. Beck's triad is cardinal signs of cardiac tamponade. So I talked with pericarditis about this sac that surrounds the heart. So as you see the heart, if you've ever seen open heart on TV or live, you know that the heart will contract, but when it does, because of the way the muscles are striated, there's also a certain amount of torque as it beats there. So the heart needs some protection from the lungs and everything else around it. So this is what the pericardial sac is, and there's usually just a thin layer of serous fluid that lubricates and allows that heart to bounce around and torque and do what it needs to do. But there will sometimes be a fluid collection. It could be blood, it could be infectious matter, pus, or other things can get in there. And as that pericardial sac starts to fill up with this fluid, whatever it may be, it squeezes on the heart. So the heart, as it contracts, can't refill, so we have a consequent loss in cardiac output. So they're going to be looking shocky, obviously. EKG is going to be negative. They aren't having an MI, but it's more of a heart failure picture. And the definitive diagnosis for this is an echocardiogram. Definitive treatment for this is a Pericariocentesis. I remember being taught this in EMS school and saying, I don't think I'm ever going to try this in the field. You basically take a very large needle and go in under the xiphoid and up into the pericardial sac and pull that fluid out of there and ideally resolve this. In RER, it was done under ultrasound guidance, and as the cardiologist would pull this fluid off, the pericardial sac would just refill very quickly. So whatever was leaking very badly and could not be reversed. In researching this, I came across this study, I think in an online journal. In America, we don't tend to do a whole lot of autopsies, at least not in Nebraska or surrounding areas here. In Europe, they're really, for lack of a better term, autopsy happy. They autopsy everyone. And on autopsy, these folks found that about 3% of deaths had some sort of cardiac tamponade involvement. So I think this might be a little more common than we'd imagine. And I think a lot of our patients who come in coding, your patients in the field or patients brought in by EMS and cardiac arrest, may have some cardiac tamponade involvement. Not that would really change too much our initial treatment of them. We'll still go through our ACLS protocols, but just keep this in mind as a differential and keep that Beck's triad in mind. Now the reason I know this patient so well and the reason I had such issues with this is that this patient was my mother-in-law. So whenever I give this presentation, I kind of dedicate it to her, and if there is a heaven, I know she is up there, and I know she is embarrassed every time I do this lecture. But that was a tough night in my ER for me. So moving on, another kind of burning, subtle chest pain patient. They come in. This pain is going to be on one side of the chest. It isn't going to be center chest pain. It's just going to be on one side. They can usually define it really well. Normal EKG, normal labs, normal x-ray, normal everything. And a lot of my more savvy providers won't go that deep into diagnostics on these folks here. Go into a history on them, and have you ever had chicken pox? Ever. And the chicken pox virus, the varicella virus, when you have chicken pox, and obviously most of us had it in childhood, that virus will stay latent. It stays latent in the nerve cell bodies. And at some point, decades, you had it when you're 4, and suddenly you're 70, and suddenly you're having this thing. The virus will kind of pop out. You're having some sort of a immune issue or something like that, and that herpes virus comes out and causes shingles. Now shingles, when you think of it, is usually associated with these very painful red, usually like popping open vesicles, but the very intense burning pain that you have can manifest a couple of days before these vesicles start popping out. As you can see, these vesicles will spread out along a nerve root. So our dermatome diagram that we use for our spinal cord injury patients also map out where these vesicles and where this pain is going to manifest. So it's in those nerve cell roots that will pop out, and it pops out along one of these dermatomes here, first with the pain and then a few days later with these vesicles. So these are treated with steroids and antivirals and all that kind of stuff. And ideally, diagnostically, you catch this sooner or later so they don't have the $1 million cardiac workup and then suddenly a couple days later have these vesicles popping out with shingles. Another one, not really really much of a zebra here, but we check everything. Typically younger patients, EKG is negative, lab is negative, negative x-rays, typically worse on palpation or deep inspiration. And this one, after going through sometimes a long workup, sometimes not so long, we'll go with a diagnosis of costochondritis, which is basically this cartilage which hooks the ribs to the sternum gets inflamed. Usually it's associated with a cough, and so flu season like we're going through now, people are coughing for weeks, and then suddenly they'll have this intense chest pain. So this is a diagnosis of exclusion. A lot of times, this is more common with my abdominal patients, but sometimes with my chest pain patients, as I'm sending them out the door, I say, our job here is to check for the things that will kill you dead tonight, and we haven't found none of them. So you can follow up with your doctor, but this is what we think is going on. So we can also call this a trash can diagnosis, but we've checked everything and come up with 3 lemons. So we'll send them home with some anti-inflammatories and tell them to use a warm pack. Arthritis can cause this, and then here is our zebra, xiphodynia, and this is a costochondritis associated with pregnancy. If you remember, in pregnancy, all of your cartilage and joints tend to soften, so the pelvis can open up, so the baby can get out during childbirth. Sometimes the trauma of childbirth will cause, and the softened cartilage will cause the xiphoid to be pushed a little bit out of line. So a few days or even weeks out of childbirth, a woman will complain of this very intense chest pain in the xiphoid area. This is because that xiphoid is in a whole new place and is poking places that it didn't typically poke before. So there's a real trivial pursuit zebra for you there. A few other things you'll see. Shoulder pain oftentimes is characteristic of referred pain from abdominal issues, so gallbladder issues, or spleen issues. Spleen issues, especially traumatic, we got to jump on right away, and those will typically refer up to the shoulders. Seen a lot of gallbladder patients come in with this sudden onset chest pain, and as we dig deep into them diagnostically, it's a gallbladder issue and not a chest pain issue. Hiatal hernias you may be familiar with. Some conditions, and this is typically in older patients, part of the stomach will pop out above the diaphragm, and this causes typically kind of a chronic super GERD, you know, as they have really bad chest pain from acid reflux, basically exacerbated by this extra stomach that, you know, some years or even decades ago popped up above their diaphragm. And this can be something they carry around for decades, or it can be corrected surgically if there is a need to. One last little case study here, and I'm sure you've seen these folks in your ambulance or in your emergency department. Somebody comes in and they say, well, it started out, I was having some chest pain, it kind of hurt a little bit, and then it started to having some difficulty breathing. So then they start breathing a little faster, and then my face got numb, and then my hands got numb, and you know, it kind of goes worse, and then of course that makes the chest pain worse, and that makes them breathe a little hard, and they get very anxious. So who do these folks, when they're at home, where do they go to? Well, of course, we all go to the internet. So what do you type in? Well, I'm having chest pain. Let's see what the internet has to say about chest pain. Well, probably one of their first hits is going to be something like this. You know, you're totally going to die.com. So does this help with the anxiety? Does this help with the hyperventilation, with the difficulty breathing, all that kind of stuff? Obviously, no. They're going to look at that and they're going to like, oh my God, I am about to keel over and die. So they're going to call 911 or call their friend or something like that. And they're coming in with these, you know, spasms, because that's what's going to happen when you're when you're hyperventilating and all that kind of stuff. So you look at it and say, it's just an anxiety attack. Big deal. But you want to use this diagnosis very, very cautiously, because there are plenty of things, plenty of things pathophysiologically that can cause you to become anxious. So it looks, the outward manifestation is an anxiety attack, but there might be some underlying pathophysiology that is going to kill them dead tonight. So in our ER we have order sets that we can put in. Some can be activated by nurses. So for chest pain patients, for suspected MI patients, we can put in cardiac chest pain. It's all lab work, IV, nitro, aspirin, all that kind of stuff. For a woman come in, burns when I pee. Nurses can activate a protocol where we'll get a urine sample and a pregnancy test. And each of my doctors has their own pet order sets. So for abdominal pain, Dr. E likes Nubane, and Dr. S likes hydromorphone. One of my doctors, Dr. R, he has what he calls the Crazy Girl workup. And the Crazy Girl workup, you would think that is, EKG, Ativan, and out the door. But he is not new to this. He is not one of the beloved doctors, but he is very careful and very good. And his Crazy Girl workup is EKG, D-dimer looking for pulmonary embolism, white count, chemistry, thyroid studies, because that can cause major problems, maybe even consider a head CT. All these things, because we want to make sure we're not missing anything and missing something that might have caused this anxiety that they're presenting with. So this is not a slam dunk diagnosis, that anxiety. So I want to end with that little precaution for you there. So in summary, when you get that negative EKG, your work is not over. In fact, it's just beginning. There's a lot of things you can do carefully on a physical exam that might lead you sooner rather than later to the final diagnosis and management. So assess your patients, treat them, monitor them, and chase those zebras, because they are out there. So remember, just like Rosanna used to say, it's always something. So I hope if it isn't an MI, you can figure out what's going on there with them after listening to my presentation. Thanks very much. I can't take questions in this format, but if you do have any questions, you can email me at nursecurtis@windstream.net. Be glad to correspond with you. You can follow me on Twitter and see where else I'm going to be teaching. And you can also look on YouTube. If you type in Nurse Curtis as a search, you can see me droning on more and more if you've enjoyed what you've seen here tonight. Although a lot of the case studies on there are excerpts from this lecture here. So thanks very much for listening, and good luck.